Good evening, everyone, and welcome to today's advanced meeting. We're very honored to have a fantastic panel with us today. From surgery, we've got Professor Sivanayagam and Mr. Nick Rubos. And from medicine, we've got Dr. Ali Aminazad, who's our respiratory physician. And from our thoracic anesthesia panel, Dr. Des McLeod, Dr. Brian Cowie, and I'm sure many more thoracic gurus in the midst of our audience, specifically people who have gone overseas to do a thoracic fellowship. Thank you all for being here today. This evening, I'm also joined by two co-chairs. I've got Dr. Clive Ruckbook, our director at Eastern Health, and Dr. Harsh Dubey, one of our VMO anaesthetists. I'm grateful for their support in leading the discussions. Now, our literature review will be presented by Dr. Joe Wheatley, who is currently undergoing his basic training at St. Vincent's Hospital. Now, before we begin the presentation, I would like to acknowledge the traditional owners of the land upon which the meeting is being hosted and pay respects to our elders, past, present, and emerging.
So today, our structure will basically follow this from 1 to 7, preoperative assessment, 1 lung ventilation and its indications, lung isolation techniques. The top 3 points are familiar to most of us, at least in theory. Point number 4, difficult airways and exactly how to troubleshoot them can be a little bit more of a daunting part of practice for those of us who do thoracics infrequently. So we'll spend a little bit of extra time making sure that the tips and tricks are shared in detail to give people safe and reliable options to move forward when dealing with difficult airways. The right-sided DLT tube placement will be built in part into the virtual bronchoscopy component of this talk, and there will be some very useful tips shared by Peter Slinger as well when it comes to right-sided tube placement. Hypoxia management, once again, we'll talk about optimization of oxygen, circulatory support, and just a reminder, there are QR codes that are built into the presentation. So every time a piece of literature is discussed, one can always scan the QR code to access the study in a bit more detail.
So, fantastic survey response. Thank you all for taking the time to complete the survey. The last time we did the analysis over the weekend, there were 203 consultants and 15 trainees. Now, in terms of the distribution, well done, Eastern Health. Very proud of you. We also want to have a special mention to Northern and Canberra. You guys have been supporting Advance from day one. Thank you very much. I'm also very excited that Monash Health has come in such a big group, so thank you all. We also have lots of guests coming from interstate and New Zealand, people from Peninsular Health and also Latrobe Regional Health. Thank you again for joining us. In terms of distribution of practice, as you can see, majority of our consultants have more than 10 years of experience.
So the majority of the attendees here rarely do thoracics, and it is done, but mostly while they're on call. So this talk would actually be directed towards that particular group, given that it comprises almost 70% of the overall attendees. And we will be reliant on those who do thoracics a little more commonly, perhaps weekly to monthly, to really share their insights and contribute their expertise during this discussion. We'll start with a case scenario. So this will lead into the preoperative assessment discussion. We see a 75-year-old male, ASA3 for Ravat's upper lobectomy on the right side, ischemic heart disease, anemia, type 2 diabetes, OSA, mild COPD. So a very standard thoracic patient with complex medical issues. But here we've also got the factor of a difficult airway. This patient had a C-spine fusion, had a failed intubation, and that required an LMA rescue. He had, however, more reassuringly, had no issues using a classic 5 laryngeal mask.
In terms of investigations, it was the pretty standard set investigations. So the usual FBE, renal function, and the respiratory function tests, and transthoracic essentially normal.
Some of the themes that we want to discuss here, we can look at the preoperative investigations and the survey that was put out. And what you can see from that is that a lot of people just rely on predetermination by the surgical team. There's also a very large emphasis on respiratory function tests. A lesser percentage, 21% on transthoracic echo, some type of stress test, and then cardiopulmonary exercise testing in 15% of respondents. We might just kick off to start with by asking the surgeons, what do you often order for your patients prior to an operation? And I know, Sevan, you've got something to say on this.
Thank you. For me, this is not an unusual patient. And from my point of view, the singular determinant I have is the transthoracic echo. It need not be a stress test, but a transthoracic echo. And what I will be keen to look at is any signs of pulmonary hypertension, because the patient's got OSA, is on CPAP. Pulmonary hypertension is probably going to be the only negative. The other numbers with the standard RSTs we would have done, I'm pretty sure all the surgeons in the group would probably agree that we would have all looked at the RSTs. I don't know whether the CPAP I would have ordered for a standard upper lobectomy. However, if the patient had pulmonary hypertension, then I would certainly be concerned about it, because it's not just this operation, it is the longer term outcome as well, because we will be taking another part of the upper lobe goes, and then the pulmonary vascular resistance will go up further. In this day and age, particularly with stage 1 tumors and with the molecular studies and personalized treatment, we need to really have robust criteria for borderline patients to be assessed thoroughly, because there are alternative treatment options. And particularly with the advent of immunotherapy, for me, my gut feel when I meet the patient probably counts for more than any of these numbers do. But if I was to objectively pick one, I would be very keen to look at the TTE.
Thanks very much for that. I basically agree with that. At Eastern Health, certainly, there's a multidisciplinary team meeting, respiratory, oncology, and obviously the thoracic surgeons. So by the time the patients present to us, they've pretty much been worked up. But certainly the ones that get run by me every now and then, one of the surgeons will come to me and say, Clive, I've got this patient. It's more for a cardiac issue rather than the respiratory function itself. For example, someone with hypertrophic obstructive cardiomyopathy plus mitral regurg or something like that. And then you really want to look at the cardiac function in that setting. Ali, I might ask you from the respiratory side if you'd like to comment.
I agree with both you and Sivan. As a respiratory physician, we put a lot of stress and weight on the respiratory function test. In this patient, an FEV1 of over 70%, TLFO in mid-60, says it might be okay. But for a patient who already had CABG, they have diagnosis of COPD, although not confirmed by this lung function test, as there is no obstructive defect on this one, as I can see. Having said that, echocardiogram is also important, but I do see pulmonary hypertension patients in the clinic, and I can tell you echocardiogram is not a great technique to diagnose, rule in or rule out the disease. So a lot of the times you have some pulmonary hypertension, echo is normal. A lot of the times echo could show pulmonary hypertension, but when you do right heart cath, there is no significant pulmonary hypertension and it's all diastolic dysfunction. So it is a combination of these tests that would be useful. As Steven said, functional status of the patient is important. Obviously, you need to have respiratory function tests and echo prior to making a genuine decision. What I found, and I have access to both in private and public, is cardiopulmonary exercise testing. If it is available, it's a great tool to not only diagnose a respiratory disease or heart disease, but also classify, is it pulmonary hypertension, left ventricular dysfunction, diastolic dysfunction, or it is ventilatory limitation due to restrictive lung disease or obstructive lung disease, or whether it is just lack of fitness of the patient, in particular, if they are going through chemotherapy or become deconditioned prior to surgery. I believe cardiopulmonary exercise test, if it is available and you have access to, can answer a lot of questions. Obviously, you cannot rely on one single test, but it's a combination of different modalities that you use to risk predict your patients.
Thanks very much. Now, I might just get some of the anaesthetists in the audience to chip in as well.
So it's Des McGlade here. I was just wondering, nobody's focused much on his hemoglobin at this stage. Patient's anemic. That's important with sort of focusing on his cardiorespiratory function, especially when you consider what we're going to do. We're going to do one lung ventilation and we're going to need him to be able to tolerate that. If he becomes hypoxemic and is pre-existing anemia, that's not a very good combination. Nobody's mentioned it at this stage. We're always interested in what his predicted post-operative pulmonary function is going to be like. It's a right upper lobectomy. So assuming that the lobe is actually functional, he will probably lose about 15% of his respiratory function just arithmetically on that, which you could take it down from his pre-op spirometry. If you took 15% off, say 73%, still keeps him up there in a fairly, what we would say post-operatively, from the point of view of tolerating the procedure, into an acceptable range.
Thanks very much.
I'll just go through the basic literature and the textbook teachings on what one needs to do. So Peter Slinger's three-legged stool, that I'm sure everyone will be familiar with, comprises of three things for assessing the patient preoperatively for a thoracotomy. They need pulmonary function tests, and in that they need to have their parenchymal function looked at as well, and we need to assess their cardiopulmonary reserve. So on pulmonary function tests, probably the most important thing that we want to know is their predicted postoperative FEV1, which can be calculated by taking the pre-op FEV1 and timesing it by the percentage of lung tissue that's going to remain after resection. And the cutoffs that Slinger quotes that are really major cutoffs that are important for us to note is a predicted postoperative FEV1 of less than 40%. We start to see a major spike in increased risk of major complications, and less than 20% is probably unacceptable to proceed. And we need to start thinking about different approaches to manage this patient's either lung cancer or disease process. Parenchymal function, we can also calculate predicted postoperative DLCO as well. It has a similar cutoff of 40%, which is handy. I think it was one of the surgeons there was mentioning arterial gas pressures. Historically, I think a PaCO2 of greater than 45 was used as an exclusion for lung cancer resection. There's equipoise in the literature as whether that alone is useful, because a reduction in FEV1 will very often accompany a decrease in PaO2 or a rise in PaCO2. And as has also already been mentioned, cardiopulmonary reserve is probably the most useful predictor of post-thoracotomy outcome. If we have CPET, then a VO2 max of less than 15 mils per kilogram per minute is probably where our cutoff for an acceptable risk is, although the American College quotes less than 10. Of course, it's time-consuming, expensive, and limited availability, but luckily correlates very well with a 6-minute walk test. So we can do a 6-minute walk test for our patients with around half a kilometre using the equation you can see on your screen, probably equating around a VO2 max of 15 mils per kilogram. We can also use a 2-flight TARES test. 2 flights of stairs probably corresponds to a VO2 max of around 12 mils per kilo per minute. This systematic review and meta-analysis published about 5 years ago, we commonly ask our patients whether they can manage a flight or 2 flights of stairs. This research group sought to seek where that threshold of exercise stress was, and they found that their increased risk of postoperative complications happened at around 10 meters, which arguably is around 3 flights of stairs, but 2 to 3 flights of stairs is probably the cutoff where we need to start thinking about referral for CPAP. So that's Peter Slinger's 3-legged stool, and those are the cutoff values just to highlight that we've just been mentioning. But of course, this is talking about pre-thoracotomy, and many of our patients that we see are now getting surgeries via a VAT approach. This is a nice graph taken from Slinger textbook. It shows that in the blue, the open procedures, we start to see a major spike in risk of postoperative complications at around that predicted postoperative FEV1 of around 40%. In the VAT group, however, we don't see that spike until predicted postoperative FEV1 drops below 30%. So we've got a little bit more room to move with these patients that are having a VAT. In terms of high-risk groups, elderly patients are at high risk of complications. Respiratory complications double, cardiac complications triple in patients over 80. And Slinger, as we've already mentioned already from one of the experts, recommends that the transthoracic echo as a minimum should be done in these elderly patients to rule out pulmonary hypertension. The other high-risk group is patients who have an intermediate cardiac risk, and evidently lots of patients presenting for these types of surgeries will, by default, have some intermediate cardiac risk factors. The revised cardiac risk index score, when they went back and looked at the data, they found that there was barely any patients undergoing thoracic surgery included in the original risk index. So they developed this thoracic revised cardiac risk index score, and this is to risk stratify patients and see who needs non-invasive cardiac preoperative investigations. It's well validated as per this article that I've included, but potentially underutilized, and perhaps if we have time at the end, some of the experts can speak to that. Finally, just to close up, this is the American College of Chest Physicians guidelines. The highlights here from this algorithm really is that they recommend that if a preoperative, so not predicted postoperative, but a preoperative FEV1 or DLCO are greater than 80%, if both are, then no further cardiopulmonary reserve evaluation is required. For those that fall into the somewhere either less than 30 or between 30 and 60, we can risk stratify and either put them through a shuttle walk or stair climb test in the clinic, but some may need CPET, for example, the ones with predicted postoperative DLCO less than 30%. And this risk stratifies them into high risk, moderate risk, or low, high risk being an expected mortality of greater than 10%, and low risk being expected mortality of less than 1%.
So we had the opportunity of interviewing Professor Slinger, and he's going to speak a little bit about the pre-op assessment.
It's basically all done for us, for me. And that's because over a period of about 30 years, chest physicians and surgeons and us, anesthetists, have all come to agree on the same principles, that you need some qualitative assessment of lung mechanical function, of lung parenchymal function, which is diffusion capacity, and cardiopulmonary interaction. If you could imagine, I hate to keep dragging you back to the 80s, but 30 years ago, there was just worldwide, there was no consensus. And then gradually, chest physicians and surgeons and us have come to agree on the same principles. And so it's now amazingly international that we all agree on this. And so this is being done. The chest physicians are triaging the patients based on this and referring them to the surgeons. And so by the time they get to us and we see them in clinic, this is basically all laid out for us now. And this is usually where I work, part of the anesthetic pre-assessment. And it only comes up to be an issue when something unusual happens, a wedge resection suddenly might turn into a lobectomy or a pneumonectomy, and then is the patient going to tolerate that?
I might ask, Stephen, as Professor Slinger said, in practice, how often do you actually see an operation get extended? So, for example, a patient start off as having a lobectomy and now it's turned into, let's say, a pneumonectomy. How often do you see this in practice?
So I think it's important to recognize that a wedge resection turning into a lobectomy is unusual because you probably looked at the CT. You might end up taking more lung than what you intended. It's still a wedge. In units that do segmentectomy procedures, where you set out to, let's say, a tumor less than 20 millimeters, there is enough evidence if it's a T1 tumor within 0 preoperative staging, then a sublobar resection is probably acceptable. And when you go in there, you find that your margin at the segmental level, what you thought might be a posterior segment in the upper lobe might be somewhere closer to the apical segment and posterior segment border. And you need to take a lot more, and you end up either doing 2 segments or end up doing the lobe. That sort of thing can happen. Where we see the biggest problem will be someone misjudging or the preoperative imaging being remote from surgery. So if you had a 6-week delay or more between your CT scan, PET scan, and your operation, and it's a central tumor, then you are running the risk that you go in there and you find that the lymph nodes are either stuck to the ongoing PA to the lower lobe, or the tumor itself is stuck to the artery. Then in centers where you can't do a vascular sleeve resection, then you might be forced to abandon. And sometimes intraoperative decision-making on that resectability of that tumor before you even take some of the other vessels may not be possible. And if that were to happen, then you actually have this inadvertent need to convert to a bigger procedure. And it is notoriously difficult with VATS. As the VATS lobectomy skill set has improved, people are undertaking more and more central tumors with the VATS approach. And then the biggest disadvantage of the VATS approach to a thoracotomy is that you don't have the advantage of the tactile feedback. And sometimes we do misjudge that. And so my recommendation for that will be you should not undertake a central tumor without up-to-date imaging, both PET and a CT. Usually people rely on the PET CT. I personally feel uncomfortable. I still like a contrast CT if I'm dealing with something closer to the vessels. Pneumonectomy is usually because of an accident, because you end up tearing something that you can't salvage and it ends up being a pneumonectomy, and that's usually a catastrophic circumstance because you probably didn't plan for it. Some patients are lucky, then get away with it. But if you have a problem in a borderline patient, then I think that's the kind of time when you need to call for help. The RV systolic function, I think if the RV is generating significant pressures, then it's probably okay. We'll be worried about if the RV is sluggish. And we also touched on the CO2. I would always test the PCO2 in those patients because those patients are so borderline. And in a right upper lobe, we'll get away with it because it's the easier, apart from an isolated middle lobe. Upper lobe is probably the one that with the least consequence. But if you were taking a lower lobe in a patient with that kind of borderline pulmonary hypertension, CO2 retainer, you really need to assess that patient carefully. I mentioned earlier that in this particular case, I wouldn't have placed too much emphasis on the CPET, but that's because it was an upper lobe, but not that I don't like the CPET. We do use it, but we normally would walk that patient 2 flights of stairs in our clinic. It's much easier to do that ourselves, and then you get a feel for the patient. So I wanted to take back that comment when I said I wouldn't do the CPET. That was mainly because I would have thought that in this patient having an upper lobe, there was enough reserve in the lung that I would have been fine. But because of the ischemic heart disease and the anemia, I didn't see that hemoglobin when it was presented. That would be something, would be a red flag. Would definitely need that sorted before we undertake the procedure. But specifically from an echo point of view, if the RV systolic functions good and the diastolic function in the LV is not a problem, then I would just do a resting blood gas And that's just to reassure, because there is an occasional patient with OSA, you will find that they are, and look at their bicarb as well and see what their general homeostasis is like and then make a judgment. But for an upper lobe, I will have a lot more looser threshold for proceeding.
I think everybody who's having a resection of any sort, lobectomy, segmentectomy, pneumonectomy, is going to be monitored at least the first night. Monitoring would be usually in vasoarterial pressure, certainly pulse oximetry and ECG. Okay. They wouldn't be in an ICU. Here we go to a step down, which is a bit less intensive, one nurse for 2 beds in an ICU. And that would be the standard. Some patients with wedges, they would just go to a regular ward bed. And most of our patients with wedges are going home the next day or the second day as soon as the surgeon can get the chest tube out.
Peter seems to talk about a number of step-down destinations that they're able to use, which aren't necessarily HD or ICU. I just wanted to ask surgeons, so Nick and Krishna, for example, you've got practices across both public and private hospitals where you do thoracics. What are your post-operative destinations?
Most times, for whatever reason in private, we tend to have patients that go to HDU after most thoracic procedures. To be fair, many times they don't need to, as was mentioned in the last video, but a couple of places I work at are geared up to look after them that way. And there's only one ward that will take thoracic patients. So depending on the bed status, they'll either go to the ward or to step down. Lobectomies always go to HDU. Most of us could go to either. And again, it depends on if the patient's otherwise quite well. If they don't have much in the way of underlying problems, then they'll often go to the ward. A couple of private hospitals that work, the ICU likes to look after them. At Box Hill, again, they're always seen by the anaesthetic team, and the judgment's made once they've reviewed all the things we've looked at. As soon as they're found to be in a slightly higher risk group, then they'll often reserve an ICU bed. On some occasions, we've actually reserved an ICU bed and sent them to the ward at the end when they've been very stable and gone much more smoothly. So I would say, especially more recently, we're less fixated on going to HDU unless there are specific problems. And the specific problems are obvious, is what we've discussed. Those things are putting them into a higher risk group. So that's my experience. And the good thing is that we always have pre-planned these things and people understand what they're in for, the patients and the ward and or the ICU. So luckily, we very rarely run into trouble.
And do you find HDUs and ICUs, when we do use them in the public and private setting, cognizant of the very specialized fluid management that a thoracic patient would need post-op, especially following a major resection?
Pneumonectomy, exceedingly rare. Haven't done one or seen one in years, but previously when we do them, we would just assume that no one knows what a pneumonectomy needs in terms of fluid management, but also in terms of drain management. And that's on the back of having seen things go wrong. In general, because especially lower risk and easier thoracic cases go to HDU quite often in private, they're very well clued up in how to look after them and they don't need much coaching. They're normally pretty spot on with them.
And Stephen, you'd be in a unique position to comment on this, being the cardiothoracic director at probably the largest Victorian thoracic hospital. Do you think there's space for step-down ward-level care where the nursing staff is specialised, there's room for hemodynamic monitoring, but we're not specifically in HDU? And do you feel this is something feasible that we can achieve in the future?
Yeah, I think, for us, it's unique because our patients go to the ward because we have a dedicated 4-bed area where they can be monitored. And there was a period of time, say about 15 years ago, where I would have said general ICUs were an independent predictor of mortality after pneumonectomy, because when a patient's go into ICU, they'll get a catheter, a urinary catheter. And then people will test the urine output and then you will run into trouble in general ICUs. There's a lot more awareness, and as Nick and the guys who do so much work in private know that the private ICUs are pretty well geared for that these days. But in highly specialized hospitals or where there is adequate volume, having dedicated nursing staff interested in looking after these patients make a huge difference, because even the ERAS protocols and getting them out of hospital will come down to the attention to detail during the first 24, 48 hours. If you don't look at things early enough and get the analgesia right and things like that, then the discharges get delayed. So I think that as more and more lung cancer screening type cases get done in the next couple of years, you will see that expertise growing at the ward level.
Now, we might take the step forward and go into bronchial anatomy. We'll use the bronchoscopy simulator from Toronto. So we'll start off with the carina. So we can see just on the screen, we've got the bronchoscope going in, and this gives you a sense of what level we're at, and then a bronchoscopic image on the right. So we'll start off with the carina. This is a fairly wide structure, so between 1 and 2.1 centimeters in women, and between 1.5 and 2.5 centimeters in men. We've got these very clear semicircular cartilaginous rings along the anterior part, and it's incredibly important just to make sure that even at this point very early on that you're really well oriented to anterior and posterior at this point. Now we'll go down the left first, denoting left, and we can now travel into that left main bronchus. Now we're starting to see, one thing that I did forget to mention is the trachealis that forms the posterior wall of the trachea. Now, as we go down, there is a little bit of a common misconception that the trachealis or the longitudinal muscle only goes down the right. That's not in fact true. It does go down the left. And this long run up, this left main bronchus, is typically about 4.5 to 5 centimeters long in most people, and therefore relative to the right, more straightforward in isolating with the bronchial blocker. It also can, and we'll see that as we go through, look a little bit like the trachea and the carina. So here, if your orientation is not correct, say if you think to the right of the screen is in fact posterior and the left is anterior, this actually might look like the left and right main bronchus. So it's really important just to get the orientation right and know how deep you are. However, if you go down a little bit further, so just going into the upper lobe of the left, you can quite clearly see that it is not in fact the right main bronchus. And just to note, these are usually of equal size. And the angulation here is not quite horizontal, but just about there, essentially going from sort of 10 o'clock to 3:30, 4 o'clock. And that's quite different to what you would see in the carina. Now, pulling back, so all the way to the carina, and then we'll go down the right side next. Now, the right main bronchus can be very, very short. Typically, it's about 2.5 centimeters, and anything over 1.5 or so centimeters does make it a little bit easier to block with the bronchial blocker. In between 2.5 to 10% of the population, the right upper lobe takeoff can also be very, very close to the right main bronchus or off the trachea itself. Now, just going down into the right, now we'll immediately see some structures of interest here. So we can see this little structure here, which is the right upper lobe takeoff. Now, this is the first carina that we see in the right main bronchus, and it demarcates the division between the bronchus intermedius, which is just here, and the right upper lobe. Just keep in mind the relative location of that right upper lobe takeoff as we go down into the bronchus intermedius. Now, this here is another carina. So this essentially divides your right middle lobe and your right lower lobe. It's a little bit different to the corresponding segment on the left side, as the right middle is actually quite small relative to the right upper. So probably about a 60-40 split here. But what's really interesting here is this carina here, and this was actually something that was shown to me by Des McGlade when I worked with him at St. Vincent. But the point at which it essentially joins the anterior wall, at this point, if we were to antiflex, and for a moment, let's just picture we've put a right-sided tube in, and our bronchial lumen is somewhere there, sort of mid-bronchus intermedius, and we've poked through and we can see the middle and the lower right lobe. And we've antiflexed at this particular carina, and we're now pulling back. Now, what do we find? Now, that's going to about 2 o'clock, and almost always, another few degrees at roughly 3 o'clock, we will see the right upper lobe take off. So once again, if we've got a right-sided DLT just sitting there, what we can do is use this carina to guide the placement of the right upper lobe orifice with the right upper lobe takeoff, just by antiflexing, following, pulling back, and just twisting a little clockwise, 1 more, or maybe 3 or 4 more degrees. Now, it is important, just on the topic of effective exclusion of the right upper lobe and making sure that you've put the right-sided tube properly, is that perfect is often the enemy of good enough. So it's important that to try and line up the right upper lobe orifice with the takeoff as well as you possibly can. But if you could see some degree of overlap and some possibility of ventilation, that is often good enough for cases that really need a right-sided double lumen tube. Now we'll pull back, just appreciating the muscle layers. Now, the longitudinal muscle layer often tends to go down into the lower lobes on both sides more clearly than the middle lobes or the upper lobes on the left. And we see that across both parts of the lung. Now, I've shared relatively basic level of understanding that I have when it comes to placing DLTs and my bronchial anatomy. Now, I did want to ask Brian Cowie if you're online to see if you've got any other perspectives or opinions to share.
I would say in general thoracic practice, there are very, very few indications for a right double lumen tube. I think in most community hospitals outside a transplant centre, a right double lumen tube is not indicated, and the indications are few and far between and may include centres that do unilateral lung transplants, so a left lung transplant. And outside of that, I don't think that the procedure is indicated. I think that a not uncommon anatomical anomaly where the right double lumen tube doesn't work at all is the takeoff of the right upper lobe from the trachea. And having had one last week, it happens in about maybe 1% of the population or something. So why people would persist in putting in a device with very variable right-sided anatomy, I'm not completely sure, when a left double lumen tube is simpler to put in and will get you out of almost every single situation in a non-transplant centre.
So we'll just move on to starting off with the absolute indications for one lung. They're pretty straight and simple, really. So to control distribution of ventilation, and that might be for traumatic bronchial disruption, preventing contamination to the healthy lung, whether that's blood or pus, or probably outside of the operating room somewhere else in the ICU, but to facilitate single lung lavage as well. In terms of strong surgical indications, they're all pretty obvious things. In thoracics, pneumonectomy, lobectomies, lung volume reduction surgery, thoracic aortic aneurysms, and the orthopedic and cardiac operations you can see on the screen there. And I'll just flick through this quite quickly, but there are perhaps some more relative surgical indications where two-lung ventilations have been presented as an option. So minimally invasive esophagectomies, there's some literature to suggest that it could be done on two lungs. And those thoracic procedures that you see there that are so small wedge resections, maybe some bleb resections, fat strains of pleural fluids, those sorts of things, there are multiple case reports suggesting feasibility, although they're not very widespread. I'll just flick through this. This is an SR meta-analysis looking to suggest that minimally invasive esophagectomies can be done on two lungs, and they have relatively equal postoperative mortality and outcomes and relatively equal intraoperative mechanics. And PaO2 and postoperative oxygenation is probably better on two lungs. However, the main story with this SR meta-analysis and the other papers in the thoracic sphere that I'll just touch on in a second is that there's no randomized controlled trials, and all the studies included in this R meta-analysis were very small. The follow-up time was probably not very long. And they don't include the surgeon's rating or quality of exposure during the procedure. Again, this is a single center study from a single surgeon, just suggesting these are the operations, the thoracic operations that you can do on two lung. And as I say, there's loads of case reports suggesting that it can be done, but it's not very widespread.
Next, we'll just touch on the relative contraindications for one lung ventilations, where two lung ventilation might need to be considered. And commonly, the things that we see might include severe hypoxemia, COPD, hemodynamic instability, pulmonary hypertension, intraluminal masses, known or suspected difficult airways. I did want to just talk to the surgeons here. Stephen, what do you think? How feasible it is to do a decortication in a sick patient on two lungs?
I would do that on two lungs because it actually helps with the decor, like as long as the anaesthetist is prepared for an occasional period of intermittent apnea and doesn't complain, then it will be mostly okay. And actually having the lung inflated makes the peeling off process much easier, right, when you are decoding. If it is a parapneumonic effusion with an empyema type picture and you're going in to wash out somebody, that is where two lungs will be very difficult. But in those kind of patients, when you usually isolate the lung is actually inflated in most places anyway, and it's gas trapped and doesn't go down very well. And it's a judicious use of as quickly as possible trying to uniloculate that cavity and wash it out and get out. But in a person who's got a little bit of fibrothorax, a little bit of trapped lung, I would possibly do this with the two lungs because it's a lot easier.
That's excellent and quite eye-opening. It's always worth having that conversation to those of us that do occasional thoracics with our surgeon when you've got a particularly sick patient about this feasibility and just exploring it. Now, one of the other things that we spoke about recently was the use of things like tissue plasminogen activators for these sort of patients for clearing up empyemas. Did you want to elaborate a little bit further on that?
Using thrombolytics, I have tried it a few times for patients, and I don't want to be very straightforward and say that always works, but to be honest, it almost always works. So it's a very good technique for patients who are not very well having vast procedures, especially if they are really unwell and have a lot of other comorbidities.
Perfect. That gives us another option to explore.
Yeah, and we used the PICCAIN to introduce the thrombolytic and have a second drain as the drainage drain, a proper chest tube at the bottom. And that usually gives you a mechanism to introduce the thrombolytic, leave it clamped, and then unclamp. And even if the patient goes to theater later, it's a much easier procedure because a lot of it is already softened and you can actually finish the procedure much quicker.
The trick there that I find it very important is do a proper ultrasound assessment of the chest and find a reasonable locule prior to having that locule drained by radiologist. Because quite often the radiologist find a reasonable, very best pocket of locule. They put a chest drain and then drain the fluid. And then because the tubes are very small, then we can't do a lot of intervention. But if we find by bedside thoracic ultrasound the best locule, the best location, and point the tube to where we want to put the enzyme and use a size 12 chest drain, that would be ideal. And then giving the thrombolytics, it has to be a mixture of TPA and also Dornase. So one on its own doesn't work. And then usually 3 days is what we do. Sometimes I only do one injection and all the fluid is drained. And then I don't need to do the next. So that's a very useful technique.
Thanks very much. Yeah, so the next section, we're just going to start looking at lung isolation techniques. So really comparing a single lumen tube and a bronchial blocker with the double lumen tube. And we'll sort of seek to answer those 5 bullet point questions that we've got on the slides there.
So what you can see here is obviously we had a survey question about equipment and choice for lung isolation, and 100% of the survey respondents chose a double lumen tube as their first choice. Of those who responded, there were a small group that said other. So other than a single lumen tube or bronchial blocker, they might use some other means. And we can take into account our patients who've had tracheostomies and things like that as well. So obviously then the double lumen tube, as Slinger's already referred to, becomes difficult. So what would be your method of choice there? And we'll open that up to the audience.
It's this here again. I've just come back from the TAS meeting which was held in Montreal, and Edmund Cohen, famous for the inventor of the Cohen blocker, which probably most people out there know about, they might not have used. You asked me, would anyone use a blocker as their primary lung isolation device? Quite provocatively, he said he did, and was querying why people would use a double lumen tube. I think he's the one who's out on a limb a little bit.
Yeah, and I think he's been doing it for a few years, because in neuro anesthesia, when it was in Spain, I was there and he spoke about bronchial blockers. And I'm sure Desi might have said the same at this current meeting. Is his preferred method is to put down a single lumen tube, especially if it's a difficult airway, or especially if they're going to ventilate post-op, and then he'll selectively bronchial block and doesn't have to change his tube at the end. And that's what he pushes. But you can see from the survey results here, most people would prefer a double lumen tube, and most of our surgeons, I believe, would prefer a double lumen tube. So I agree with you. It's not in keeping with what we would regard, I suppose, here in Australia as standard practice. If you call to theatre as a more senior thoracic person, and I'm putting it to all the anaesthetists out there, to troubleshoot a double lumen tube. So an occasional thoracic anaesthetist has put a tube in and they're having difficulty with isolation. What would be your process to troubleshoot that double lumen tube?
I just use my basic technique, whether I was the primary person putting it in, and I'll go, assuming with the left, because almost all the time, as Brian alluded to, it's left. I would just go down the tracheal lumen, and we're intraoperatively, mind you, I presume, are we? Or are we?
Yes.
And identify the carina, and then go in and try to identify the right upper lobe and then the middle lobe, and be confident that I've got both of those. Now, if the surgeon's operating on the right lung, that, it can be difficult. They're just going to have to withhold surgery. We're going to have to reinflate the lung and do that identification. I've had a couple of times we get called in and the whole tube has gone down the right lung, and the anaesthetist has imaged it with the bronchoscope before they started, and mistaken the carina to be where the right upper lobe takes off. The whole tube is in the right lung. So we've had to, in that situation, you couldn't do the identification, as I said. Pulled the whole thing back, and then we correctly positioned the tube with the left tube in the left main bronchus. And then we started again, and we had the same problem. So we repeated this, and it just seemed to be there must have been an odd angle for the left main bronchus coming off, that every time we put the component of the tube down the left main bronchus and then left it, it sort of flicked itself back into the right lung. In the end, we had to pull the tube out and put in a right-sided tube at the surgeon's suggestion, actually. And that worked well, but That's just a one-off anecdote.
That's my experience as well. When I'm called to the theatre, it's almost always the case that the tube's been forced down too far. And that's obviously, people are reasonably anxious or they're using a reasonable amount of force to put the tube in. And my preference these days, and we'll come to this later on in the talk, is to use smaller rather than larger tubes. So if you're not really paying attention to it's not paying attention to detail, it's a numbers game. How many of them you've put in, there's a good chance you're going to put it in too far. And I do a similar process to you. If it's intra-op and I just want to try see what's going on quite quickly, I basically pull the tube back to 23 or 24 centimeters at the lips, drop down the tracheal lumen, try identify the carina, and then troubleshoot from there.
I don't do regular thoracic cases. However, I do reasonable enough to occasionally get called in to troubleshoot. I'm not sure whether my method helped, but it has helped me. Though I pull the tube all the way, not all the way out, but the bronchial lumen is still in the trachea, and I place a bronchoscope through the left lumen and I guide the DLT into the left first. Then you come out and check from your keel lumen whether you are in the right place. It has worked better. I'm happy to listen to anyone else's experience and feedback.
No, I think that's perfectly acceptable. In fact, it's one of the ways to establish the lung isolation to start with, which we might approach later, where you put the bronchoscope initially to intubate the patient through the bronchial lumen and then guide that bronchoscope into the left or right bronchus and then railroad the tube off it. At least you're going into the correct bronchus.
Sorry, just a quick thing. Sometimes when the tube is in the left side and you think everything's hunky-dory and then you start ventilating and then you get a leak. And sometimes I think if the tube gets soft and sort of bows up inside the mouth, just pushes the balloon out a little bit and you just have to keep an eye on it. I've had someone put their finger on the double lumen tube just to keep it in the left main stem bronchus. The pressures with ventilation sometimes just push it out of position after you've checked it and you get a leak.
Yeah, I think it's more than just the pressures of ventilation. It's manipulation in the chest, movement of the patient, all that type of stuff can really cause these tubes to displace. So you've got to be able to troubleshoot it.
I think blockers are good. And I think generally speaking, the indication for a blocker is a difficult airway. So it's one of the options in the patient with a difficult airway requiring lung isolation. The tracheostomy, I think that's where blockers shine, really, unless you can get your double lumen tube in from above, which you usually can't. But given a choice, I'll always place a double lumen tube, just because of the flexibility it gives you. If you want to suction secretions, if the surgeon wants us to show them anastomosis, or if they're going to clamp a bronchus and they want to be sure they're clamping the correct one before they fire the stapler, we can bronchoscope for them. You can do that with a blocker, but it means deflating the blocker, stopping your ventilation, re-inflating it. It's just a bit more of a production. So I'll usually place a double lumen tube.
So just a reminder for all general anaesthetists that rarely do thoracics about the type of blockers that are available. It obviously depends on your institution, but those are the four that are most commonly found.
So the next question that we had was bronchial blocker use in challenging airways. Now, some of the more interesting parts to this was that it's largely something that people have never really done before. There is a small group of people that are comfortable putting them in despite not using them commonly, and a very, very small group that's happy to put them in confidently. Now, we did have someone who was happy to use a single lumen tube with a bronchial blocker. We invited some people from interstate where this is slightly more common practice. However, due to a couple of issues, they weren't able to attend, so that might have come from them. Something of interest though, there was a bit of a sub-analysis that we did looking at regular thoracic anaesthetists, and only about 59% of them were comfortable placing a blocker versus 20% of non-regular anaesthetists. So blocker use, even in the hands of experienced people, is not necessarily something that everyone's happy to do.
We did a sub-analysis on what type of bronchial blockers are available at the institute that you work at. So you can see the polls up on the screen now, and you can just, while we're speaking, submit your answers.
Clive, what do we have at Eastern Health?
We have the Arndt and the Cohen.
Brian, I might ask you what you have at St. Vincent's.
Yeah, we have two, probably the easy blocker that's more in stock now. The other thing I would add to the conversation, I think particularly for the occasional thoracic anesthesiologist, is that sometimes even really experienced people who don't do thoracics often for a case like this get fixated on, this is thoracic surgery, I must put a double lumen tube in. And a case I was called in with a near miss was an otherwise really sensible team who had called for help to put a double lumen tube in. And by the time I got in the room, there had been 6 attempts at intubation. And that doesn't include multiple oropharyngeal airways putting in. The patient was still maskable. And our otherwise really good general anaesthesia team were just fixated on, it was a right upper lobectomy and we cannot do the case without a double lumen tube. And it's just not true. So even though we're doing thoracics, don't forget to just go back to basics. And if a patient is a really difficult intubation, just get any kind of airway in to start with. It does not have to be a double lumen tube, and a thoracic case can be done without a double lumen tube in a patient like this who has got red flags, OSA, sleep apnea, and a previous failed intubation. So there's a lot to be wary of here, and the patient does not have to have a double lumen tube if it's not easy getting a standard single lumen in.
Absolutely. Thank you so much, Brian. I think that's really excellent advice. Margaret, I see that you're with us. Do you know what types of bronchial blockers are available at your institution?
Hi, thanks for inviting me. Sorry, I'm so late. We've only got the hook or the aunt. I've seen a rep and the video for the easy blocker, but we've not had it yet. I've been doing thoracics fortnightly for about 23 years, and I've only actually put in a blocker twice. So it's not something I think that most people do often, certainly not my institution.
This is another clip from Slinger's recording.
I guess in all parts of medicine that occasionally you need it, and if you don't ever use it, when you do need it, you're going to struggle. So it's good to use it sometimes when you don't absolutely need it. So when, for example, if I'm working with a trainee, a left-sided VATS wedge resection, to me, that's a perfect case to teach a blocker, and you could do it yourself because the left-sided, left mainstem bronchus is nice and long and it's not going to be crucial. They aren't going to be there for a long time, dissection. Blockers, as far as lung collapse, blockers work quite well. Okay. There are a set of tricks with blockers that are very important. Always ventilate with 100% oxygen for at least 3 minutes or more before you inflate the blocker cuff. Because once you inflate the blocker cuff, any gas trap distally has to be absorbed. Nitrogen in it, you all know this, the lung collapses more slowly. All the blockers now have a suction channel. I put on low suction, -20 until that lung is really well down. The other thing is I position the patient. We go in the lateral position. I don't inflate the blocker until we need it. We're going to just go on one lung ventilation. Like I don't inflate the blocker and then position the patient because they're always going to move. So leave it deflated, put it down, get it in the correct side, leave it deflated until you need it. And then when I go to inflate the blocker cuff, what I do is I actually watch with the bronchoscope and I shut off the ventilator. Okay. And I let that lung collapse as much as it's going to collapse. Is I watch the end tidal CO2 and it takes like 20, 30 seconds to go right down to zero. And then under direct vision, I inflate the blocker. Okay. And then we start one lung ventilation. It always takes 6 or 7 mils, by the way, for these blocker cuffs. A double lumen tube, your bronchial cuff takes 2 or 3. This blocker always takes 6 or 7. And when you do that, of course, and then you've got atelectasis in your ventilated lung because you're ventilating with 100% oxygen and you've got a period of apnea. So then you've got to do a recruitment maneuver of the ventilated lung. That's the only thing. So with those tricks, blockers, you'll get good lung collapse. Okay. But the downside of blockers is they can move. The margin of safety in positioning a blocker on the right side depends on the length of your right mainstem bronchus, which is usually about 1.5 centimeters. If it's 1.5 centimeters, that's fine. But if it's less than 1 centimeter, a blocker is not going to work. You just don't have enough base there to position a blocker.
Really, I'll just run through some of the major pros and cons to both double lumen tubes and bronchial blockers. And we can take you through a little bit of the literature around it as well. But this BJ article summarized it quite nicely. Really, the advantages of double lumen tube, outside of what we mentioned already, is you can alternate ventilation to either lung, and they're normally much quicker to place. The real downside is in that you might need to switch them if there's postoperative ventilation required, and they do have a higher risk of causing airway trauma. The blockers, they can be used with tracheostomies, single lumen tubes. We can selectively isolate lobes, but the real downside to the bronchial blockers, at least according to the literature, is that they have a very high rate of displacement intraoperatively, and they do tend to take longer to insert. This is an SR meta-analysis, sort of just suggesting what we've said already, really. They're published over 10 years ago now. They found that bronchial blockers were longer to place, but potentially not clinically relevant, only 51 seconds longer. But they did have a much higher rate of malposition. And for double lumen tubes, they also found they had a significantly greater instance of airway injury and hoarseness post-op. Published a little bit more recently than that. This was a multi-center prospective observational study published in 2019. They had a very large patient cohort. They found the malposition rate for double lumen tubes was less than half that for bronchial blockers. But if you look at how many bronchial blockers they put in compared to double lumen tubes, it's worth appreciating this is probably just due to frequency of use. And as Slinger has already mentioned, whilst there is a use for bronchial blockers, it's something that perhaps we need to practice and keep in our arsenal a bit. Again, this is another slide where it's again saying the same thing. And it's unsurprising that double lumen tubes are causing more dysphagia in these patient populations. Again, it's another systematic review and meta-analysis that's just saying that the main result really here is that the double lumen tubes cause dysphagia at an odds ratio of 5. Both are associated with morbidity and mortality as well. There's plenty of case reports that can tell you one's better than the other according to the mortality. But I thought this was quite interesting. This is when a bronchial blocker had been moved to accidentally proximally and created a ball valve effect over the endotracheal tube, and that left the breast stacking and an arrest. Similarly, as we've already mentioned, double lumen tubes can be pushed in too far. And if they're pushed in too far, they can breast stack and cause pneumomediastinum and barotrauma.
So we'll come to a question now. Can the surgeons tell the difference between a bronchial blocker or a double lumen tube?
I can answer that one. No, if it works, you can't. So as long as it's working and it works well, I haven't seen that there's much specific differences. Theoretically, the issue is the right upper lobe inflating when you're trying to block the right. It can be an issue. As shown in all the polling, there's only been a very small number of cases where we've used a bronchial blocker, but proportionally, yes, it certainly did displace or fail more often. So in short, as long as it's working, it can't feel a difference, but it's much more likely to fail intermittently and repeatedly when a blocker is used. At least that's my experience, but that's over many years in a few other places.
If I can add something, the Peter Slinger's talk on that was absolutely brilliant, but there's one other thing that we do these days is that once you place it in place and you haven't inflated it, once the patient's position and we have prepped and read, I would put my thoracoscope port in and I would then ask the anaesthetist to disconnect the circuit and I would start CO2 into the operated side. And that would allow me to deflate the lung completely. And once we have satisfactory deflation, the problem with the bronchial blocker from a surgeon's point of view is the gas trapping. So if we were to, we can't effectively deflate the lung. So I would use the CO2 because these days with VATS and robotic, we tend to use CO2 a lot. And I would completely deflate, get the balloon inflated, and then commence ventilation and the recruitment part. That's worked very well. And after that, we don't normally see any problem unless I manipulate the bronchus. And me manipulating the bronchus is probably more of a reason for the displacement than anaesthetist placing it or the tube falling out by itself.
So in regards to choosing a lung isolation device, as was just mentioned, if it works, it works. And this study really showed that as well. This is actually from the Toronto General Hospital, and Professor Slinger was on the article. They just compared surgical exposure and graded it from 0 to 10 with 3 different bronchial blockers and a left dual lumen tube. And the results are on the screen. You can see here that there's actually, they found no difference or barely any difference between the devices. Of note, though, the malposition rates, again, were much, much higher for the bronchial blockers. So should the choice for bronchial blockers be case specific? And I think we've alluded to some of these already. Really, bronchial blockers may be thought of as being first line for patients with a laryngectomy or a newly formed tracheostomy where the double lumen tube isn't going to go in easily and there's a short distance from stoma to carina. Certainly, and we'll touch on this in the next part of the topic about the anticipated difficult airway, where it's easier to place a single lumen tube. Brian Cowie has already mentioned that there is a tracheal bronchial anomaly that occurs in around 1%. And certainly for selective lobar blockade, bronchial blockers could be used. This is a slide from Cohen. This essentially says the same thing that I've just said. So this is probably a pertinent question. This paper sought to answer whether general anaesthetists that do limited thoracics, whether they should be putting bronchial blockers in or should be putting double lumen tubes in first. They grouped 22, one group of a left double lumen tube, a univent blocker or an ART blocker. Between the different groups of anaesthetists with limited experience, they found that the results were equal across the board. However, this is a very small study, but it does ask the pertinent question, and perhaps we'll go over to the airway panel to whether you think this is a suitable question. Should we be putting bronchial blockers in if we have limited experience?
What do you see generally in your practice as being the most common hindrance for people to use bronchial blockers, Des? given that you do use them from time to time?
But if you're comfortable with them and you know when to use them, there shouldn't be any impediment. But it's a very specialized technique. I put them with right-sided double lumen tubes. I think they're really for people who are doing thoracics regularly and have done them and have been mentored on the first one rather than just sort of trying to wing it and see what happens. The other thing that surgeons haven't alluded to is that our surgeons don't like them. They'll take them if that's all the best option. But if they're going to do a resection and they want to see where to put a staple margin and they say, okay, can we inflate the lung now before I deploy the stapler? And if you've got a blocker in there, I'll tell you, the lung goes straight back up and then we've got to wait around for about 10 minutes before the lung will go back down just so that they can deploy the stapler. So I don't like using them or use them only as a last resort when they're actually doing lung surgery and resection. Certainly anything extrapleural, I'm quite happy to pop them in there, including a sophrectomy, something like that. If they go in the chest, just the lung gets down, the surgeon does what they need to do. And as Nick alluded to, if it is in the right place, the degree of isolation is indistinguishable from a double lumen tubes.
And so this is another survey question about the determination of the size of our DLTs.
We wanted to see what people use as their methodology for it. And you can see from that, you can just read the pie chart for yourselves. Gender alone, patient's height and gender, plus a CT scan, and then some other means, be it measuring the tracheal diameter at the clavicles or something like that. So the most common one seems to be just gender, with males taking a 39 and a 41 and females taking a 37 and a 39.
Slinger is going to give a talk on how he sizes his tubes.
Very simple, except that I'm probably more and more getting towards smaller double lumen tubes. That I've had very rarely have I ever had a problem with undersizing a double lumen tube. I can't say I've had a lot of problems with oversizing, except occasionally you get a small patient that, you really worry that you're causing trauma. So basic men are average height man, let's say 170 centimeters or more is probably a 39, and under 170 is a 37 for me. With a very large man, I don't use many 41s anymore. It's just unless I get a very large man, and women usually 37s, or a small woman, say under 160 centimeters, a 35, and a very small woman. And then I'll go to the CT and measure the left main stem bronchus, because our 35 double lumen tube, I happen to keep in for 9 millimeters head, and that's a 9 millimeter the diameter of the bronchial lumen. So if the left main stem bronchus is less than that, then we go to a 32. We do have 32s here. 32s used to be an issue for us because our pediatric bronchoscopes wouldn't go through 32s, but we have newer, smaller pediatric bronchoscopes fit through a 32. So now there's no negative thing for us, no hesitation to use a 32 if we think needed.
But I really wanted to get to the point of the unanticipated challenging airway and the use of Cook exchange catheters. Yep, so this is the view that you might get. We'll just go straight to the survey question. So as you can see, most people don't commonly use the Cook airway exchange catheter. And the next slide would be Peter talking about some of his tips.
This was an issue that tube exchanges are not to be taken very lightly at all, can be very difficult. I have a whole bunch of tricks. So first off, tube exchange catheters, you got to have the right tube exchange catheter. And I think they're only made by Cook, as far as I know. And there's two sizes, large and small. I've got them here. So you want the largest tube exchange catheter that will work, which is you always want to use the large, the 14 gauge if you can, but it won't go through a 35 double lumen tube. So you've got to use the small one. The other thing is, well, I should have said this at the beginning. Tube exchange is always the two-person technique. That other person doesn't have to be another anaesthetist. It could be the nurse. It could be the surgeon, whoever. You need another pair of hands. One person to be the cameraman. Always going to do this with a video laryngoscope. The other person actually do the tube exchange. Okay. So now these tube exchange catheters, okay, Cook, because there were certain number of patients who had the old tube exchange catheters rammed, made a hole in a bronchus because they were stiff. Like the one end is stiff and the other end is soft. Okay. So, Cook decided to make one end soft, like they were all stiff before. The trouble is, I think they made the soft part too long. Okay. So that That soft part is like 25 centimeters long. Okay. You only need distal 10 centimeters, really. You just, the portion that may poke into a bronchus. What this means is to get to where you get the stiff portion into the glottis, okay, here, that means you're going to have the distal tip down the right main stem bronchus, okay? You're going to be at least 20 centimeters, and that's, it's 10 centimeters from your cords to your carina. And so that means that's going to be down the right main stem bronchus. It's not a problem. You just got to live with that, okay? So you got to be gentle. Like all these things we're doing in the airway, you have to be gentle. Okay? If you don't get it far enough down, the bronchus, what will happen if these are your cords, and what will happen is that your tube will still want to go. And imagine this: your tube will still want to go down the esophagus. Okay, you've got to have the stiff part in to convince your tube to go down. And the other thing is, this is the standard tube that we have here in our hospital. This is a Rouge. Most double lumen tubes, disposable double lumen tubes, they have this design which has no bevel, or they have a small bevel. And I'm not a shill for the Fuji company. We were talking about Fuji double lumen tubes. We're talking about Fuji bronchial blockers. But Fuji also makes a silicone double lumen tube called the Sil Bronco. Okay. We keep a supply of these. These are basically designed for tube exchange. Okay. They've got a very nice bevel, and they're really flexible. Okay. They're so flexible that if you use them just, with a standard laryngoscope, sometimes it's tough to get the tube to go this so flexible, but they're great. They're good. They're better than other double lumen tubes for tube exchange. Everything has to be lubricated to the nth degree. So spray everything inside and out with silicone. And then with this tube, I can't say it's always a piece of cake, but it's definitely easier than, your stiff tube without a bevel.
We'll just very briefly mention this article that I found. There's multiple case reports in the literature of bougies leaving some microplastic and blue debris in some of the double lumen tubes. And so this study published in Anaesthesia sort of sought to quantify it. It looked at 3 double lumen tubes. The brands on the left are the Malincrots, which I believe is also called the Shiley, P3, and the Sil Bronco that Pete Slinger has just been mentioning. And the 4 bougies it looked at were the Frover, P3, Proact, and Portex, although the Portex was immediately excluded as it actually didn't fit down any of the DLTs. They did one pull through with each combination of DLTs and bougies. Then they put a fiber optic bronchoscope down and graded the degree of shearing. Moderate is orange. Mild, there was some easily noticeable blue residue. And severe, there was one or more large fragments. And so the Shiley and Frover bougie and double lumen tube really shouldn't be used together, but we should be conscious of using bougies at all with double lumen tubes.
Get straight to the degree of comfort that our audience has with right double lumen tube. Because as Brian said, there's not many situations where we need that. So as you can see that most of us are not particularly confident at putting a right double lumen tube. Definitely not as confident as a left double lumen tube. And if we go straight to the recording by Peter.
I can give you lots of tips for positioning right-sided tubes. Do you know our website for bronchoscopy? So you know your bronchial anatomy. Okay. So the next thing is that if you look at the bronchial anatomy and in the right bronchus intermedius, the right main stem bronchus, the right upper lobe takes off and becomes the bronchus intermedius. And then you have your segmental bronchus between the right middle lobe anteriorly and the right lower lobe posteriorly. And as I'm saying this is one thing that I beat on the residents is anterior, posterior. And you, even when you're on your side, you have to focus your thinking, always have your anterior is, 12 o'clock, posterior is 6 o'clock. And you've got to maintain that orientation because if there's blood or pus down there, you get lost. Okay. So you have to be constantly thinking of keeping your bronchoscope in that orientation. Now, when you look down the right bronchus intermedius, you're looking at the middle lobe and lower lobe. So that carina between the two goes horizontally, the patient's supine, horizontally, and it kind of goes from 10 o'clock to 2 o'clock, okay? Because the right middle lobe's pretty small and it's kind of D-shaped. But that rhina is that's the key to positioning right-sided tubes. Because once you know where 2 o'clock is, you know where 3 o'clock is, your right upper lobe takeoff is at 3 o'clock or 3 to 4 o'clock. But that's the thing, as you go down, you find that grind, okay? And that's also, you know you're not too far down. You want to see the middle lobe or your tube's too far down. It's very easy to get right-sided tubes too far down. Then if your right-sided tube is just in the right lower lobe and you look with the bronchoscope, you get very confused. But you've got to find that grinding. And then once you do, you get a nice view of that. Then you pull your bronchoscope back and then you look for your right upper lobe. And then it's not a matter it's just a matter of rotating the tube a bit so that hole, the ventilating hole for your right upper lobe, is at 3 to 4 o'clock where the right upper lobe orifice is. You don't have to have the full right upper lobe orifice visible in that ventilating side slide. If you can just see a little bit of it, then your right upper lobe is still going to get ventilated.
The next survey question about our hypoxia threshold.
What is the comfort zone for anaesthetists and what hypoxia threshold would they accept? As you can see, the majority of the respondents were happy with the response of 90 to 94% saturation. Very few wanted 95 to 100% saturation, and then just in decreasing numbers, 85 to 89, a very small percentage would accept above 80%, and there was a very even smaller percentage who accepted some other number. From my perspective, the answer to that's actually quite easy. I'll accept whatever I can get with my measures to try and improve the saturation. And I think if you're going to do thoracic anesthetics, you've got to get used to the tone of a low saturation and not be scared by that tone because you're going to experience it. I would certainly be comfortable in the 85 to 89% range in a complex patient rather than trying to cause barotrauma or something else to get a better saturation.
I know I generally concur with what Clive just said. I mean, we all like it to be the higher the better, or much more comfortable, because the option is to pull out a CPAP circuit. And once you pull out a CPAP circuit, especially in a VATS, you're really interfering with the conduct of the surgery because the lung's going to blow up in the enclosed hemithoracic space. And basically, if you want to be there all day while the surgeon's operating, so I'll take 85 to 89. But on the caveats also that the hemoglobin is good and also that the patient's got a reasonable cardiac output, because if any of those three go down, we're already pushing the degree of saturation down. If the other two are down, then you start getting a multiplying effect on the flow of oxygen through the body. So I think you just keep those other two in mind.
I disagree with you there, Des, a little bit. I put the CPAP system on as soon as the SATs in the 91 to 92 range, knowing that they're going to drop further while I'm buggerizing around. And you can start the thing at sort of 3 litres and 1 millimetres of mercury, and the surgeons don't notice because I do this all the time and they don't notice. If you had to drive it to 10 to get a good number, then yes, that's going to blow up the lung and that's going to get in their way. But you can try a little bit of oxygen and often that works. The thing that made me late to this meeting, I had the CPAP device on at about 3 litres and 1 millimetre of mercury. He never complained. I don't think it bothered him, but it got my SATs back up to 92%. So everyone was happy.
Thanks, Margaret. So next up, we've got Peter's video discussing how he manages hypoxemia.
2 kinds of hypoxemia during one lung ventilation. Severe and acute, and the answer is get back on 2 lungs. Okay. And then find out what was wrong. Okay. Gradual. Okay. Then there's a series of steps. First step is always make sure your tube or blocker is in the correct place. Be sure you're ventilating with the correct FiO2, that you haven't mistakenly stayed on 50% or something. And then usually my next move is going to be a recruitment maneuver to ventilate. And then trying to optimize your PEEP. Everything I read, everyone has a different approach to PEEP during one lung ventilation. Unfortunately, there is no magic here. I usually start with 5 and then go up, doing a recruitment maneuver each time. Some people start high and come down. Certainly morbidly obese patients need more PEEP. in my experience, and I don't think I'm alone in that. I think that that's shown by the literature. Those are the simple steps. Okay. CPAP is generally a non-starter during minimally invasive surgery. Sometimes if you and the surgeon have a really good working relationship, you can use a little bit of CPAP, and you have to partially inflate the lung. And then we get into a variety of tricks. Now, thing I have to mention is TIVA. Many people like me over the years have done studies to show that TIVA is not superior to volatile anesthetics during one lung ventilation. And every time you look at these studies, TIVA is always a little bit better, but the margin of error is so small. I'm saying that poorly. The range of results is so large in each group that they overlap. The TIVA is always just a little better, but I have now come to believe, and I'm not alone in this, that TIVA definitely is better. Okay? Do I use TIVA? No, I'm usually too lazy. We don't have target guided infusions here, but if the resident sets up TIVA, I'm fine. But if it's a patient, patient who's had received bleomycin, I want to keep the FiO2 down. Patient who's morbidly obese, patient with pulmonary fibrosis, patients I think are at high risk. We're doing bilateral procedures, collapsing one lung and then collapsing the other. Patients I think are likely to desaturate, then I'll go with TIVA for sure. And I actually do now honestly believe that it does make a difference. Other things, okay, those are the simple steps. There are fancy things to improve. We can use the bronchoscope and just inflate a segment. We can just blow oxygen down the bronchoscope and inflate a segment of the lung. That's kind of like a party trick. And the other thing that does work, particularly with TIVA, is inhaled pulmonary vasodilators. Here we have nitric oxide because we do lung transplants, we do cardiac, but almost any hospital has prostacyclin. And there are, Floland is the trade name for it. And there are recipes out there. You can look it up and you can deliver it to the ventilated lung through a little nebulizer like you might use for salbutamol in a ventilated patient. And it works. Thing is, it doesn't work like that. First of all, it's going to take 10 minutes to set it up and then it's going to take a while. The other thing is if you go back on 2-lung ventilation, second time you deflate the lung, hypoxic pulmonary vasoconstriction has a bit of one of these inducible reflexes that each time it relaxes and then comes on a bit stronger each time. So you delay, reinflate the lung, tell the surgeon a joke, and then let the lung go down again, and things will start to get better each time.
So PEEP is obviously important for optimal pulmonary vascular resistance, VQ mismatch, etc. There are strategies to look for optimal PEEP. This was a very good study published in 2022, a large multi-center RCT, including 1,000 patients or more for lung resection surgery. And they sought to answer the question, is a individualized PEEP strategy to lower driving pressure better than just standard protective ventilation? They looked at postoperative complications and some intraoperative mechanics. Both groups got alveolar recruitment at 3 different time points: at the start of mechanical ventilation, start of one lung, and then again when they resumed 2 lungs. And that was in 5 centimeter of water increments for 5 breaths, up to 15. That was their recruitment. The individualized PEEP group started at 10 centimeters of water PEEP and decreased it by 1 centimeter of water at a time down to 0 to find the optimal driving pressure, the lowest driving pressure. And in the standard group, when on 2 lungs, it was just 8 mils per kilo and 1 lung was 5 mils per kilo. They didn't find a difference between postoperative complications, but they did see a difference in respiratory mechanics. And this slide sort of nicely shows that. The left-sided chart has medians and interquartile ranges for driving pressures. And the driving pressure guided ventilation group quite clearly had better driving pressures intraoperatively. However, that difference between the control group and the study group decreased over the period of the operation. Potentially they needed to re-recruit during the operation and that may have changed their outcomes, but they did have a better PaO2 in the study group, but only marginally.
Okay, we're going to end the meeting on Peter's last snippet, which is on his ventilation strategies.
Like I say, I'm basically using 5 of PEEP. in almost everybody, unless they have severe COPD or unless they're morbidly obese. I think they're going to need more PEEP. And then I usually adjust up. Some people will go the other way. They'll go very high and adjust down. There's actually physiologically, it really makes much more sense to go high because the compliance curve in the lung is different on inspiration and expiration. But if you go high and come down, it's probably a better way to go for the lung to start low and go up. But again, that's just a habit and laziness. More than that, as far as driving pressures, I'm certainly very nervous if we're getting a driving pressure more than 20. And another thing along this line is, you probably appreciate this, but the number our machines give us for PEEP, that's not actually the PEEP that the patient is receiving. PEEP the patient receiving is a complex interaction of what we found on the machine, the resistance in our circuit, and the auto PEEP the patient already has. And that number we don't know. And maybe sometime in the not too distant future, the technology will help us with that. Say, this is actually the patient PEEP. Okay. This is what their total PEEP, this is what they're receiving. So I'm kind of off on tangents. I guess that's kind of, I'm just, if what did I want for Christmas under the tree? Maybe that would be, a real monitor of PEEP. But other things, recruitment during one lung ventilation, yes. How often? Whenever you think of it, really, I'm sure you can't do it too much. FiO2, get it down as low as you can. Can I prove that makes a difference? Not really. Maybe inflate the lung with a lower FiO2 at the end of the case. Some suggestion that that's beneficial. All those, radicals that IFO2 posits.
So we're just going to conclude now, but I just want to thank Sarah for organizing this meeting. If this is the first advance you have attended, it's getting bigger and bigger. We started off at small beginnings, and it's all due to her hard work.
Thanks so much, Clive. Thank you all for joining, and thank you for staying for so long. Brian, Margaret, Des, and Clive, are there any specific tips that you want people to take home from today if they didn't remember anything? Brian, I might start with you first.
I would have emphasized there, as we've touched on with ICU patients and that we mentioned a couple of times, thoracic anaesthesia does not necessitate a double lumen tube. So be very aware in the sick ICU patient about trying to get lung isolation. In our centre, we have an issue where patients who have pericardial tamponade are on occasion referred to thoracic. And thoracics want to do a VATS approach in patients with pericardial tamponade. We refuse. And I encourage everyone listening online that in patients with pericardial tamponade or rapid AF or marginal oxygenation and hemodynamic, do not get sucked into trying to isolate the lung to drain the pericardium. You can do thoracic anaesthesia in critically ill patients without a double lumen tube.
Thank you so much, Brian. Des and Margaret, did you have anything to add?
I'd agree with Brian. Absolutely do not have to put down a double lumen. They can retract the lung themselves if it's all going horribly wrong from your end. I think it's excellent advice.
I would encourage people now, we didn't touch on it, but we were talking about different ways of ventilating, with different ways of recruiting lungs and different ways of managing hypoxemia and PEEP and so to turn on the loops on your ventilator now. The ventilators we have on our anaesthetic machines are quite sophisticated. They give us a lot of modes. They're like mini ICU light ventilators. And the monitoring that they come with, the spirometry, utilize it. I do it all the time. I love looking at those loops. I love the recruiting and seeing the changes in the shapes of the loops. And I know when I get that pressure volume curve to its steepest that I've done the right thing. I've got the compliance right where I want it. I've got the PEEP where I want it. And often you can just do it by eyeball. So just encourage people to take that on from now on because it's all there in all modern anaesthetic machines. And I think it's significantly underutilized. I never see anybody much using it, but I certainly do.
Thanks, Des.
I would just say, just communicate with the surgeons. If I look at Eastern Health, we've got certainly the very occasional thoracic anaesthetist, especially for emergency cases at night. And the surgeons and us, and I know the group of surgeons who work here, they're absolutely fantastic. You just need to communicate with them. I've even had them help me with bronchs and looking down and seeing where the isolation is. So as long as you've got that communication and you're both discussing to the benefit of the patient, I think a reasonable outcome in terms of the anesthetic and what you're doing can be negotiated. And rather than going into specifics about what to use and all that, that's what I would say, because, a lot of people are out of their comfort zone, myself included sometimes, and you've just got to ask. and try to communicate well.
Thanks, Clive. Thank you to the surgeons and Ali for attending as well. Stephen or Nick, if you're still online, did you have anything else to add?
Thanks for inviting me. It was very nice to get a different perspective. And at Eastern Health, yes, we are nice surgeons. So yes, we're happy to communicate anytime.
Stephen, you were about to say something.
Oh, no, I was just commending you and the unbelievable team and be part of it. And just to see the sheer number of people dialing in at this time of the night, to listen to something like that, but the content was superb. And thank you for having me on here. Thank you.